Okay, hello everyone. Thank you so much for joining our webinar. This is our second workshop focusing on respirators and masks in our wildfire smoke intervention series. For those who may not have attended, our first workshop focused on air filtration. And this workshop series is inspired by the work our group at OEHHA is doing on a wildfire smoke interventions review, which we hope will contribute to AB 619 work. AB 619 is a California bill that passed in 2021 that requires CDPH to develop a plan with recommendations and guidelines for counties to use in the case of a significant air quality event caused by wildfires. We are looking forward to hearing from our subject matter experts, Dr. Home, Dr. Santana, and Dr. McDonald, on their research on masks and respirators to learn more about wildfire smoke intervention methods. Just some logistical points before we get started. We will have a brief period for questions after each presentation, and then hold 15 minutes for discussion at the end of this workshop. We hope to end promptly at 3:30. Feel free to put your discussions in the, feel free to put your questions in the chat as we go, or wait to unmute to ask your questions or thoughts during the discussion portion. And with that, let's welcome our first speaker, Dr. Stephanie Home, which I think a few of us know, but Stephanie Home is a pediatrician, occupational environmental medicine physician, and epidemiologist who is particularly interested in airborne exposures and how they contribute to pediatric health and well-being. She is board certified in both pediatrics and occupational environmental medicine. Dr. Home completed an MPH in 2017 and a PhD in 2021 in epidemiology at UC Berkeley. She has led and contributed to multiple community-engaged research projects assessing the health effects of air pollution, indoor and outdoor, in California children, especially those in environmental justice communities. Her ongoing research activities include work on outdoor air pollution and its effect on metabolic and neurologic outcomes in children, as well as working on cooking-related indoor air pollution and associated health effects in children. As a former public health medical officer within the California EPA, she also has a keen sense of how research can inform policy action. Dr. Home is also the director of the Western States Pediatric Environmental Health Specialty Unit, a group that focuses on education and outreach regarding children's environmental health. Thank you so much, Stephanie, for joining us, and we're looking forward to your presentation.
Absolutely. Thanks for having me. Always fun to be back and see all of my OEHA friends and all your smiling faces. So I'm doing just a little bit of an overview of respiratory protection in kids, thinking about sort of the physiologic, both safety and protection side of things as sort of a segue into some of our other presenters. I will say, as with so many things, right? Always hard to cover a topic well in 20 minutes, but I'm going to do my best. I actually gave a similar talk this morning for an hour, and even that didn't feel like enough time, but happy to take questions at the end whenever it's useful. I'll start with this little image, which just happens to be an elementary school that put a mask on their statue of their school mascot out front during the COVID pandemic, which I think is very funny for a couple of reasons, but one of which being, I don't know about you guys, but I feel like the statue is sort of the classic optical illusion where when I first looked at it, I thought it was a bunny, but it's actually a stork. And so the, the mask is on the end of its stork there, or at the end of its beak, rather. All right, no financial relationships to disclose. At the Western States PACU get some funding from federal EPA and CDC, but none of my, and which I'm very grateful for, but none of my comments are official stances of anybody. All right, so just to sort of set the framework, there's really this major need for respiratory protection in kids, and within that sort of just a lot of knowledge gaps, a lot of conflicting guidance that gets given out by different public health agencies. And I've been working on this for a few years now. I will say I'm increasingly excited that there's stuff happening, but it's also, as there's what feels like an increasing need, right? So this is my little slide of COVID pandemic, right, is one thing that definitely raised the profile of kids wearing masks or respirators. Increases in natural disasters, many of which are related to climate change. So the two images in the middle there are the hurricane that hit Los Angeles last year, and then the really devastating wildfires in Lahaina and Maui last summer as well. The image on the far left is sort of, I feel like it's one of the more egregious examples I've seen of schools being built next to freeways. So that's an elementary school in Ohio that is literally in the middle of a freeway on-ramp. Many are not, quite that bad, but a lot of schools and other places where children spend time are really close to traffic-related air pollution as well as other industrial sources. And so there's plenty of exposures, some of which, as I said, are increasing in frequency and intensity over time. And so, all the more need to be talking about this, both as it relates to wildfire smoke, which I know is the focus of this, but also just generally, right? It's so broadly applicable. I feel like many of you have heard this from me before, so apologies if it's a repeat, but I often say that if you remember nothing else from anything I ever tell you, if you could remember this slide, I would be happy. So I'm going to go over it again, even for those that have heard it, which is that kids are really uniquely vulnerable to environmental health hazards. And that's for a number of different reasons. And there's, lots of details we could talk about under each of these categories. But if you're someone that's, got your training, your grounding in working on stuff related to adults, if you can remember these sort of 4 buckets in terms of what makes kids different, it'll give you a good framework, to kind of move forward in terms of collecting information and pulling in the folks that you need. And I'll tie these specifically to wildfire smoke as we're going through them. So the first one is that kids have behaviors and preferences that increase their exposure to a wide variety of things. The example I usually give for wildfire smoke is that kids tend to spend more time outdoors and more time active than adults do. That's good, right? Like, we want to encourage that. It's actually a problem when that's not the case. But it does mean that if your outdoor is contaminated with wildfire smoke, they're going to be spending more time out there potentially than adults would be. Kids also have differences in their physiology that mean that in the same setting, they'll get a higher dose of whatever the exposure is. So for wildfire smoke, if I'm sitting outside at a park where there's smoke blowing next to my 10-year-old daughter, next to my cousin's baby girl, even though we're all sitting on the same park bench getting the same air blowing past us, right? The baby's going to have a higher dose that she breathes in relative to her body size than my daughter, and hers is higher than mine is. And that's the respiratory stuff largely related to the fact that children, and especially the smallest ones, have a higher minute ventilation, a higher amount of air that they bring in relative to their body size than adults do. So those are my first 2: behaviors and preferences that increase exposure, differences in their physiology that increase the dose. And then the third is that kids have unique windows of growth and development that can make them particularly susceptible during specific windows, and that can also lead to sort of outsized effects by disrupting growth. So there's a lot of interesting work out of Southern California, as I'm sure many of you know, looking at changes in lung function growth related to air pollution exposure in the long term, right? And, if you think about perturbing a growing system, a change that happens at one moment might make a small difference, but if that changes the sort of slope of growth, right, you can have these huge effects down the line. And so, it's all the more reason we need to be extra aware of protecting our youngest members of society. And then kids, of course, have less ability to control their environments, both on the sort of large scale, right? We need to be the ones making sure that policy changes are happening to protect kids. But also, individually, it's impossible for a 3-year-old to go out and buy a respirator just because they need it that day. So sort of all of those different components. I will say, just as a contextual point for this, in occupational medicine, we also and industrial hygiene and lots of things, but we often talk about the hierarchy of controls. That really, the more effective things are to eliminate an exposure or substitute it, use engineering controls, use administrative controls, and then very last is PPE or personal protective equipment, right? So this is often talked about in the workplace that, you know, you can improve ventilation or you can switch to a different chemical, et cetera, et cetera. Those things are in some ways a little more challenging in environmental health, partially just because there's such big changes that need to happen, right? So to eliminate wildfire smoke, well, that there's a lot of big changes that need to happen there to our climate and to forest management practices. And, you know, this isn't something that an individual person can do. But I still think it's useful to just remember that, you know, we really are still talking about the bottom of the, you know, inverted pyramid here. And it's useful and important, and we should be talking about it, but that we should simultaneously also be working on these higher up things, right? So the facilitating behavior change to make it so there's less of a need for the respiratory protection, changing things in our built environment, like improved air filtration in schools and, you know, et cetera, all the way up. So I think sometimes because I spend so much time talking about masks and respirators, I feel like it sounds like I'm recommending them as the end all and be all, and that's not the case. So I wanted to just give that grounding to start. All right, so my like super simplified, you know, what are the things to think about for respiratory protection? I was gonna say for kids, but also for adults. There's sort of these two components. There's the filtration piece. For example, if we're talking about an N95 as an example, right? It's how many particles can pass through the material of that N95. So filtration. And then the second piece is leakage. How many can pass around it, right? So like around the edges, around your nose, around your chin, all these places where there might be gaps. And that's a useful framework for thinking even more broadly. I just mentioned N95s, but you know, there's been a lot of appropriately questions over the last few years about, well, what other devices can be used, right? Like when N95s were scarce because we needed them for healthcare, can you get benefit from X, Y, Z, other things? And really thinking about these two factors is still the way to think through those things. When we think about kids compared to adults, you know, the material that we use to make these things is likely, I was going to say always, but often at least, going to be the same for kids versus adults. So the sort of filtration efficiency of the material you wouldn't expect to necessarily be different for a kid, although potentially it could be. But there may be some differences in how much breathing resistance kids can tolerate relative to adults. That's not something we have very good data on yet. Happy to talk more about that if people are interested. But I think one of the biggest differences for kids is really this leakage issue, that because we don't have devices currently in the US that are marketed and designed for children, there's a real issue with potential leakage. And one of the things that, you know, people often talk about is sort of what age do we expect kids to be able to wear respirators that already exist on the market. And I'll just, you know, full disclosure, I think lots of people know this, but there's not great data. So there's quite a bit of, you know, pulling together what we can from disparate sources. What I've often said to folks is that, you know, we know that NIOSH certified respirators go through this sort of strict regulatory process, and we know that they're high quality products. And so if your child can fit a N95, NIOSH certified N95, and often that's a size small one, right? They make adult small in some of these products, that you should use that if you can. You know, we do expect, so this is looking at, we do expect that many kids will be able to fit those. Let me finish my sentence. This graph is showing on the x-axis facial width in millimeters. It's measured zygomatic process to zygomatic process, and then length measured from the depression of your nose down to your chin. And the sort of gray numbered grid on the upper right is a portion of the standard NIOSH, so National Institutes of Occupational Safety and Health panel that's used for sort of testing fit of respirators. And so I just took some data that's publicly available actually from craniofacial and dental researchers, and just plotted out just as sort of a you know, quick and dirty, like at least start of a way to think about these, at what age you would expect the average kid to start showing up on the NIOSH facial grid. Again, this is like super simplified, right? It's just length versus width, so that doesn't capture the whole picture. Kids' noses are less deep and their chins are smaller, and et cetera, et cetera. And this data set is 3,000, 4,000, something like that, white kids of European ancestry. So like all kinds of problems, right? All the grains of salt. But using these data, at least somewhere between ages 7 and 8, the average kid's face sort of hits this grid. And the error bars are really wide. So you can see I've put error bars both on length and width just every 3 years, just because it's too messy to look at if I try and put them on every age on the graph there. But you can see they're pretty wide. So really, basically no 3-year-olds are going to show up on the grid. But by the time you're like 4.5 or 5, some kids will. And then, as I said, by about 8, many, if not the majority of kids will be somewhere on this grid. And so may be able to use small adult-sized respirators. The flip side of those big confidence intervals, of course, is that there are some 12-year-olds who still won't, right? Their faces are just really small. And that's tricky. And there's lots of need there for not only lots of better data, right? So more diverse data, representing a more reflective subset of, or being a more reflective data set for the US population. We likely need some more, grids or other mechanism for eventually creating respirators that could be targeted at kids in the US. I do still often encourage folks, if they're able to do N95 certified respirators for kids, as opposed to, for example, other products coming in from other countries. And happy to chat more about some of those concerns if folks would like. All right, couple things quickly before I wrap up, trying to make sure I'm keeping on time so we can get to our other great presenters as well. So that was sort of the, physiologic differences piece. There are some studies looking specifically at respirator use in kids. They're not a lot. We definitely need lots more. But what exists does suggest that it is possible to get good respirator fits in kids, that kids tolerate them fairly well, and that they're fairly safe. Again, lots more needed. So I've got a couple here that I've cited looking at improvements in kids' exposure wearing respirators. And there's been at least one study that intentionally designed basically an N95 style respirator for kids, and was able to show that, yes, they were able to get a good fit. There have been some manufacturers that in various working groups and whatnot that I'm on have said that they also have found that. Again, all the grains of salt. I'm a suspicious person by nature. So until you have third-party testing to show me, I don't believe you. But I'll at least say that people have reported that that's out there. But there are no products currently marketed for children in the US. I do think that's an important distinction to make, because I think sometimes that gets a little bit overstated. And people say, well, there are no products for children, so this 16-year-old should not wear anything, or they should wear a KN95, or they should whatever, right? And you're like, well, no, they have like probably a nearly full-size adult face. Like, we have these products that we know are good and that we know should be used. So, there's a difference between being developed and marketed for children versus being useful for children. And both of those things are important. But sort of the metaphorical, right, not throwing the baby out with the bathwater. We do still have a tool that can be useful for some kids. I mentioned this briefly, but in terms of safety, again, limited studies, but those that exist that have put respirators on kids and youth of various ages and had them do different kinds of activities. So sometimes that's just a couple-minute treadmill task. Sometimes it's been, normal play without a respirator, and then with the respirator, and then some kind of exercise test, etc. In general, some of the various physiologic parameters that are being measured increase, so things like respiratory rate and heart rate, but within normal limits, right? And so certainly you would expect that some kids may not be able to tolerate these as well as others, but overall, it looks like generally respirator use in kids is fairly safe. I always say that the backstop is you want to make sure that you're using them with somebody who can communicate if they're having a problem, right? Sometimes that's an age-based thing. Sometimes that's also, you can have folks with profound disabilities that aren't able to communicate. And you just want to know that if they're using it, they can tell you if they're having a problem breathing so that a change can be made. I always like throwing this slide up. I don't know if people remember this. This was like a decade ago or so. There was a little girl that was visiting the White House, and there were photos caught. I think it's the White House press pool photo of her just like absolutely losing it on the floor of the White House. And I think it's, sort of a nice illustration of like kids just have a sort of different perception of like what's acceptable in different settings and all of that. And that, of course, will then affect their ability to use respiratory protection and use it properly. And I think we're going to have some of my co-presenters talking a bit more about some of that. So I won't go into it too much. But there's definitely been some work looking at what factors influence kids' sort of perception of respirators, and certainly design, like colors and patterns, seem to make a difference. But also the extent to which they feel like it's easy to breathe and the extent to which it makes their face hot, right? This is sort of a thing that happens with adults as well, that if you ask people what the problem with a respirator is, often it's not that they were having trouble breathing, it's just they got too hot in there. And so, that's an important consideration as well. Before I wrap up really quick, I'll just say, I think many of you on this call are aware of this, but gosh, 3 years ago now, some folks from Fed EPA, from OEHHA, from the PACEs, and then a bunch of other stakeholders all got together and had a workshop about wildfire smoke and children's health, covered a variety of topics. We'd had some working groups leading up to that. There was a whole, which should have been in 2020 and, blah, 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 COVID. But we had some working groups, and one of the working groups that brought together a whole bunch of experts was focused on respirator guidance. So all the stuff from that workshop is here. This QR code takes you right to it, so you don't have to hunt if you don't want to. But it's on the US EPA's Wildfire Guide for Public Health Officials post-publication updates page. And it includes the respirator guidance, which is really sort of a whole page of evidence-based and or expert opinion-based, where it has to be that, recommendations that can then be used by agencies, schools, whoever needs it to take those and adapt them to their population, but know that they're using kind of the best science available. And lots of folks have run with that. The image on the right is actually our Western States PACU, where I'm the director. My colleague there also works with you all at OEHHA, and some of the materials that we've produced based on those. So I'll pause there for 1 second if folks want to grab our webpage, because we've got lots of those up there. We also, of course, have, I was going to say all the socials, but that's a lie. We don't have TikTok, but we've got Twitter and Facebook and Instagram. We have some educational videos on YouTube. So doing what we can to try and expand that out and reach as many folks as we can. But lots of good mask and respirator stuff there on our wildfire page as well. So I will hand over to my co-presenters, but just to wrap up, kids have smaller faces. We know they generate slightly lower respiratory forces and may have some more difficulty complying with respirator wearing, though adults aren't good at it either, let's be clear. And that, some of the existing products really can be used to decrease children's exposure, and I don't want that message to get lost, even as we recognize that there's this huge need for a coordinated regulatory structure to really manage that whole process and make sure that we have the data and all the processes in place to get better respirators out there and available for kids.
Thank you so much, Stephanie. That was so great. We have a little bit of time for questions, if anybody has any questions they want to add in the chat before we move on.
Can I just add verbally that I'm a co-investigator on a project that is funded to look at face mask fit for children, both the science of it and the social science of it. So we'll have data coming soon on that.
Yeah, and there's actually a workshop series happening as part of the Face Up project. The second
right.
one of it was actually this morning. That's I mentioned I
Exactly.
gave a longer
Yes.
talk. That was this morning.
Yes,
And there, or sorry, the first one, and then the second one's happening in September, right, Fiona?
that's right. Yes. Yeah.
I also see a chat from Karen Revelis in the chat box. She also added some links to NIOSH and CDC guidance on masks. They have a section on children as well for anybody who's interested. Okay. Does anybody have any other questions? You can add in the chat or unmute if you prefer.
Hi, I have a question. This is Leona at OEHHA. So my question is, do you know of ways, this is not really about the science, but masks are quite uncomfortable. Do you have any recommendations on how to like wear them for longer when we need to? Because I don't really like them. I'll wear them. I certainly did in 2020. But yeah, so that's my question, is how to make them more comfortable if possible.
Yeah, it's a really good question, Leona. I mean, there's the like, you know, giant answer, which is someone should design a more comfortable product, right? It's like a major need. You know, some of it, in terms of what you can do with what's available now, some of it is just doing a little exploring and see what fits your face better. You'd be surprised how much of a difference it can be between different styles of respirators, and sometimes you can get much better fit without needing as much sort of like squishing so hard to your face. But there's not really a great answer. I know NPPTL, so the National Personal Protective Technologies Laboratory at NIOSH is working on a variety of different projects to help people figure out what kinds of products would fit them well. So they just had a like fit challenge contest thing that I think is in like phase 2. They've got a handful of projects that just made it to phase 2 of the award, and there's another phase coming. Anyways, they're doing a variety of different things to sort of think broadly about how to tell about fit. And I know your question was about comfort, but I actually think those things are related, which is that if you're having a really poor fit, it can be extra uncomfortable. So I think that's one piece of it. I also don't have any magic. I'm sorry. I'll respond to the next thing in the chat though, which is that Eric asked if quantitative fit testing is being done for children in respirator fit. And I'll punt over to Fiona to talk more about their work in Indonesia and Nepal. So there's definitely some, but not enough. Like we have so little data. I'm hoping to try and get some more going, but yeah, if anybody else is interested or excited or has money to throw around, please holler.
Thank you so much, Stephanie.
And just to quickly answer, our work in Indonesia and Nepal is doing some of that with children aged 7 to 12 using available N95 masks. So the publication of that data hopefully will be soon.
Thank you so much. We're going to move on to the next presentation, which is Dr. Santana. So Dr. Francisca Santana is an assistant professor in the School of Environmental and Forest Sciences at the University of Washington. She studies the social and psychological processes underpinning conservation and climate adaptation behavior. Her research investigates topics such as the social nature of wildfire smoke adaptation decisions in the U.S. West, coral reef conservation behaviors in Hawaii, and coastal community resilience in southeastern Louisiana. She draws on theories and approaches from social psychology, environmental sociology, and human geography while using multiple methods, such as surveys and semi-structured interviews. Her work is often community engaged and aims to co-produce science in partnership with local and indigenous communities. Prior to her faculty position at UW, Dr. Santana was a postdoctoral research fellow with the Western Forest and Fire Initiative at the School of Environmental and Sustainability at the University of Michigan. She received a PhD in Environment and Resources from Stanford University, a master's degree in Environmental Science and Management from UC Santa Barbara, and a BA in History from Yale University. Before her doctoral studies, she worked for 8 years on air quality, coastal pollution, and marine policy issues for nonprofits and government agencies, including the Energy Foundation, Earth Justice, the San Francisco Public Utilities Commission, and the White House Council on Environmental Quality. Thank you so much for joining us, Francisco. We're so excited for your presentation.
Thank you so much, Amal. Let me just share my screen. All right. Does that look okay to everyone? Okay, great. Wonderful. Well, good afternoon. Thank you so much for inviting me to share my research today. Really fascinating talk, Stephanie. I'm really excited to be learning from all of the other experts here. So I'm here to share a little bit of social science, specifically my research on understanding the role of social context in human response to wildfire smoke. So we're all aware wildfires have become more frequent and intense in the US West and Canada in recent years. And these wildfires have been driven by a number of factors, including climate change, legacies of thick vegetation from past land management, and an increasing number of people living in the wildland-urban interface. And in California, for example, the 5 largest wildfires in the state's history occurred between 2018 and 2021. And this included the 2018 Camp Fire, which destroyed the town of Paradise, California. And that fire actually was what inspired me and inspired my interest in this research topic, as I actually had some family members who lost homes and were impacted by the Camp Fire. So of course, in addition to this direct threat of wildfire to lives, homes, and infrastructure, there's this related threat of wildfire smoke, which poses serious risks to people living both near and far from active wildfires. And as many of you know, this smoke contributes to this cumulative burden of air pollution, which poses risks to really everyone, but especially to the vulnerable. So those over 65, those with chronic respiratory health issues like asthma, those who work outdoors, and importantly, as Stephanie was just discussing, children. And actually just last year in 2025, smoke from fires raging in Canada moved south to New York City, which exposed more people to wildfire smoke than any other previous event in US history. So this issue of wildfire smoke has become such a problem that recent research estimates in just the past 15 years, as you can see from this figure, increases in wildfire smoke PM 2.5 have reversed decades of policy-driven air quality improvements. And so for human society to adapt to these threats, action should be taken at multiple scales. So from national efforts, such as the recently published report from the Wildland Fire Mitigation and Management Commission, I think that came out last September, to state level regulatory actions, such as Washington State recently instituted rules to protect farm workers during wildfire smoke events, to finally this individual actions like buying an air filter or wearing a mask. And so, individual actions are only one piece of this collective puzzle, but individual behavior is really important because it can, mitigate harm and reduce the threat to personal health and well-being, support adaptation and resilience at the community level, and potentially in aggregate contribute to system level transformation. So because of this importance of individual response, my research aims to investigate the factors, both social and psychological, that motivate protective health and adaptation behavior, specifically during wildfire-related events. So just a little bit about these psychological and factors and social processes. So, individual decisions that we all make, they might be based on our awareness or detection of the threat of wildfire smoke. So this might be from smelling it outside. But the decisions we ultimately make to protect ourselves may also be influenced by social processes. So to look at what processes we might want to consider, there are a number of behavioral models from public health, natural hazards, and psychology. And some of the commonly used models sort of assume that behavior is driven by two things: threat appraisal, or essentially this perception of the susceptibility and severity of a threat, as well as coping appraisal, which is essentially the perception of efficacy. So self-efficacy is a person's sense of their own ability to respond to a threat, and response efficacy is a person's belief in the effectiveness of a specific action. But social processors are also involved in these individual decisions. So we might consider how social norms are likely to influence behavior. Social norms can be understood as these informal standards of behavior in a community. So a really classic example could be related to recycling. If you observe others recycling cans rather than placing them in the garbage, you might infer that recycling is an appropriate behavior. Whereas subjective social norms are more specific to the expectations of valued others. So an example might be an expectation by your mother that you give her a call on her birthday. So a text probably isn't quite enough. And we are also interested in this concept of social support, which can be defined as that help given or received in the context of a disaster. So social support can be informational, emotional, or tangible. So an example of tangible social support might be donating gently used clothing to families who have lost their home and belongings in a fire. So a driving question for my work in this area was, how do these social processes influence wildfire smoke protective health decision-making? So I'm going to walk you through this study and a follow-up study that seeks to answer this question. So first, we actually used a qualitative approach. So my colleagues and I conducted semi-structured interviews of 45 people who were exposed to dangerous levels of smoke from the campfire in 2018, as well as subsequent fires in 2019 and 2020. And we interviewed people in 4 counties in Northern California. And to recruit participants, we worked with 2 community groups in the region, the Central California Environmental Justice Network and the Central Valley Air Quality Coalition. And we focused on recruiting people who we defined as vulnerable to smoke conditions. So those over 65, those who suffered from respiratory health issues, and those who worked outdoors, as well as Spanish language speakers. So in this figure, you can see the counties where we interviewed people overlaid on a map of how many days in November 2018 there was a smoke plume overhead. And in the panel below, you can see the mean daily measurement of fine particulate matter during the period of August to December 2018, with that gray box indicating November 2018, which was when the campfire occurred. So in the interview protocol, we talked about a lot of things. They were about an hour and a half long. We asked participants about their perceptions of fire seasons and previous experiences with smoke and air pollution, how they sensed smoke in the air and where they went to for information about wildfire smoke, their decisions to mitigate their exposure by consulting the AQI, their perceptions of threat and efficacy, and their interactions with friends and family during smoke events. And finally, we asked participants what actions they took to protect their health or the health of others. And so to analyze this data, we used thematic analysis as well as deductive coding, sort of drawing on some of the constructs that I shared earlier from the behavioral models, as well as other empirical literature. And through our analysis of the interviews, we developed this conceptual framework to explain wildfire smoke protective health decision-making. And the framework shows how individuals might first perceive information and environmental changes due to wildfire smoke, which then informs their threat and coping appraisal. And these perceptions can lead directly to protective health actions, such as mask wearing or checking the AQI. However, frequently these social processes interacted with perceptions to alter the pathway to action. So an example, if an individual watches wildfire news coverage and smells smoke, this might elevate their perceptions of threat. And these elevated perceptions may result in wearing a mask. But social processes such as observing neighbors outdoors, gardening, not wearing masks, might lead that individual to change their mind and elect against wearing a mask when they're out in their yard. So to ground this framework in the interview data, I'll just take a moment to highlight a few themes that emerged directly through the voices of the participants. So the first theme that we found was questioning protective actions. So, during this time in 2018, 2019, we found that many participants observed really inconsistent behavior in their social circle or had to manage conflicting recommendations. So these conflicting social norms often led to confusion and questioning. So Mario said, I remember that whole controversy about the different types of masks for the smoke. Some people were saying this type of mask, other people saying, no, that doesn't do anything. Another theme was interpreting information together. So we found that by frequently checking for and then sharing that information with close loved ones, several participants described this importance of informational social support. So one participant, Sandra, explained that she resolved her uncertainty about what type of mask to wear by going to the dad source. She said, where I got into that black hole was the definition of what's a P95 or P100 filter. Should I pay more for one or the other? I talked to my dad who does machining and is around tiny particulates all day. And he was like, 95 is fine. And so I went with the dad conversation. The dad source is my go-to, probably most reliable, more than the internet source. And finally, protecting vulnerable others. So many participants explained how protective actions were often driven by the desire to protect not just themselves, but also vulnerable others. So Jill here she bought face masks for her elderly mother. She said, I'm her main support person for everything. I think I actually canceled a couple of her appointments. I got her a mask. It probably wasn't an adequate one, but I did the best I could. So we found that a lot of several participants took actions or received masks as gifts from friends and family. And these actions translated from that tangible social support into a subjective social norm, which is, again, the expectation that one should wear a mask if it's given. So just to summarize this piece of qualitative work, we learned that during novel wildfire-related hazards, like smoke events, when information is scarce or conflicting, social norms really can fill these gaps and provide information about appropriate actions. And we found evidence that social support might foster emerging subjective social norms. Of course, during this time, the COVID-19 pandemic began when we were in the middle of doing interviews and collecting data for this study. And it actually prompted us to think about how people might be responding to these health hazards at the same time. And we wrote a perspective piece discussing masking in both of these contexts. And finally, to sort of test this conceptual framework and further explore these relationships, my colleagues and I also conducted a survey-based study of US adults that really builds on these findings from the interview work. So to close my talk, I'll just share a little bit about that work, which was recently published. So again, here, the purpose was to test more quantitatively the extent to which descriptive social norms and social support are associated with these intended responses to wildfire smoke, including masking. And we decided to focus in on social support because it's actually still a bit unclear how social support may relate to adaptation behaviors. Although our interview-based study indicated that tangible social support may have spurred some people into action, other research has shown that social support may actually sometimes inhibit actions by possibly suppressing an individual's perception of a threat or potentially undermining an individual's sense of self-efficacy. So in this study, we analyzed survey data from a nationally representative sample of US adults. And this data was collected as part of the American Public Opinion on Global Warming survey in the summer of 2020. And our survey included measures of respondents' threat and coping appraisal of wildfire smoke, their perceptions of both giving and receiving social support, their perceptions of descriptive social norms, and their adaptation intentions. And specifically, respondents were asked about their intentions to wear masks, as well as other adaptation behaviors, including staying inside, sealing cracks in doors and windows, using an air filtration system, or going to a place with no smoke. So using regression analysis, so this was entirely cross-sectional correlation-based data, we did find that threat and coping appraisal, somewhat as expected, were both positively associated with adaptation intentions. But we did find that this association between coping appraisal and intentions was nearly twice that of threat. So that suggests that perceptions of efficacy may more effectively predict future adaptation behaviors. And we also found that reported descriptive social norms were positively associated with adaptation intentions. And this provides further evidence for the power of social norms to motivate behavior. And we also looked at social support as a moderator of perceptions of self-efficacy. We expected that social support might change the strength of the relationship between self-efficacy and adaptation intentions. But here it actually appears that social support may have weakened that association. But this was not statistically significant. So definitely more study needs to be done on these relationships. But in a different exploratory test, we looked at whether higher levels of social support moderated the relationship between threat appraisal and adaptation intentions. And we found here that greater levels of social support significantly weakened the effect of threat appraisal on adaptation intentions. So even though this is a significant effect, it's actually quite small. So even with higher levels of social support, the independent effect of threat appraisal on adaptation intentions remained positive, just slightly less so. But this just sort of adds more evidence to this complicated relationship between social support and how that may relate to how people perceive threat and actually translate that into action. So just to close, I'll share a few implications of this sort of pair of studies on wildfire smoke adaptation behavior and protective health action. So the first is we found that threat and coping appraisal, as well as descriptive social norms, seem to be quite key in understanding adaptation behavior for wildfire smoke and related threats. Social support may actually complicate some of the relationships between threat perceptions and adaptation. So kind of remains uncertain what that relationship really is. And overall, this study suggests that it's really important to consider the social context of individuals when designing interventions or communications promoting adaptation behavior. So this is an image showing health safety guidelines for mask wearing according to the California Department of Public Health. And one could imagine infographics like this one that consider social factors rather than just focusing on the individual. So to say leverage social comparison, communications could tell people how many of their neighbors or fellow community members report wearing masks. So I will just end there, and yeah, thank you all. Happy to take questions. So let me see if I can stop sharing.
Thank you so much. That was so great. I think for the sake of time, we will move on to Fiona's presentation, but please everyone put your questions in the chat and we will address them in our whole group discussion. Thank you again. So like I said, we'll move on to Fiona's presentation. We can see your slides, Fiona. Thank you so much. So just to introduce, Associate Professor Fiona McDonald is from the School of Law and the Australian Centre for Health Law Research at Queensland University of Technology in Brisbane, Australia. She's also an adjunct associate professor at the Department of Bioethics at Dalhousie University in Canada and a senior research fellow at the New Zealand Centre for Public Law at Victoria University of Wellington, New Zealand. One element of her research is to examine ethical issues when considering recommending protective interventions for air pollution, including air pollution disasters caused by volcanic eruptions, wildfires, and similar events. Thank you so much for joining us, Fiona.
Thank you so much for having me. I'd like to begin by acknowledging the Ningi, Turrbal, and Jagera peoples on whose lands I walk, work, and live. It's a great pleasure to be here, and thank you very much for adjusting your timing to enable me to contribute. So this research it came out of a project that I was involved in, a consortia project that was looking at the health implications of volcanic eruptions. And part of that was to think about the ethics of recommending interventions when there was very limited evidence of effectiveness or efficacy. So this presentation is based on this publication, which you can access and is open access. But I'm currently doing further work in this space. So essentially, the first question you might ask about this is, why is ethics important? Ethics is really important because it's the study of what we ought to do, not what we can do, but what we ought to do. And so ethics helps us provide moral reasoning to support better and more population-centered decision-making. And it's really important for us to think about the ethics of what we're doing and what we're recommending. So this is essentially an ethical framework that we developed. The principles are drawn from the principles of public health ethics. And again, public health ethics is the discipline of ethics that thinks about how we should, what values should be associated with decisions that can affect population health. And so we drew these values out of this literature and considered which ones we thought were the most relevant or the most important as part of a structured decision-making process. A couple of things to note at this point. Firstly, that these are in no specific order of priority, that one is not necessarily more important than the other. This is a framework that agencies can use to structure their decision-making. But it's really important to note that different agencies may come up with different recommendations at the end of it. And that's because every agency will have different values, different mission, different legislative responsibilities. They may conceptualize their sort of moral positioning differently. And we would expect the same, that what works in California may not work in another US state, and that nation states would be different as well. So what I'm trying to say here is that a lot of this is going to be driven very much by which values agencies put more emphasis on. And there's no right or wrong answer here. This is a framework that helps people understand what values they're emphasizing and why. You'll also see here that this is a framework that encourages the integration of evidence into decision making, because evidence-based public health practice is so important. But that evidence is not just about the evidence of the effectiveness of the intervention per se, in the pure scientific sense, but also tries to integrate some of the social factors that Francesca, for example, was speaking about. So I'm going to go through these in turn. So the first principle is to maximize benefits and minimize harms. And this is really important in the context of air pollution, particularly air pollution caused by wildfires, or bushfires as we call them in Australia. And so the concept here is that we need to think about, is the problem, the wildfires, does it have the ability to cause harm? What type of harm? In what context? And does the intervention maximize benefits and minimize harms? So I'm not a scientist. I work with tons of fantastic scientists, but I'm not one myself. So you'll know much more about the science-related and medical-related aspects of the impact of wildfire smoke on human health than I do. But we do know that there have been multiple studies that have examined things like excess mortality associated with wildfires, and have identified that there have been significant excess mortality. There have been increases in hospitalizations and so on associated with wildfire smoke. And we also know, of course, that particulate matter has significant health impacts, whether it's 2.5 or 10, it doesn't matter. There are impacts of those, and those impacts are both short and long term, and relate to mortality and morbidity. That those impacts are significant, are experienced differently by different groups of people, as Stephanie noted in her presentation. And so we know a great deal about the impacts of wildfire smoke on human health, and that we know that it is negative. There's still, and we also need to think about the composition of the particles, not just the size. And the composition can also have negative health impacts, and those can be unknown, and with a wildfire can change depending on what the fire is burning at the time. So the big question then is, if we've got these significant harms, what can or should we do to minimize those harms? And one of those is to think about interventions. But before I go any further, we also have to think about the harms of any particular interventions. And this is a photo of a young child who's outside during a volcanic eruption in Iceland and is wearing a mask, which is great, except for the fact that it's upside down and the wrong size. And so one of the questions that we have to consider is that whether people in getting an advice to use an intervention are going to feel that essentially that they can go outside, they can do things that we'd prefer them not to do because they've accorded some protection, even when that protection is probably non-existent, as in this case. And we also have to think, as Stephanie said, about the harms associated with mask use, and whether for some people there are significant complications and hazards associated with the intervention. So those questions of maximizing benefits and minimizing harms are really significant, both in the context of the overarching risk or hazard, but also in the context of the intervention itself. The next question is the effectiveness of the intervention. We know that some agencies are reluctant to recommend interventions when the evidence base is non-existent or limited. And certainly there has been some hesitation to recommend masks in the past by some agencies because of that lack of evidence or the very sort of thin evidence base. And the question really is a question of how much you value effectiveness. And what do we mean by effectiveness? Do we mean by 100% effectiveness? Do we mean that we know for 100% that there are a certain degree of protection, whether that's 60% protection, and whether that is considered to be effective or not? So the questions about what individual agencies are comfortable with in the context of what they think effectiveness means, whether it's effectiveness of there's an evidence base or whether there's effectiveness in respect of the protective effect of the intervention. So those questions are significant, and that sort of scientific analysis of the evidence is important. And as Stephanie noted, we have an expanding evidence base for the effectiveness of face masks vis-a-vis adults. We have much less data on the effectiveness vis-a-vis children, but there are all sorts of holes in our evidence base that remain. The second aspect of effectiveness is that effectiveness is not just a scientific construct. As Francesca was saying, there is a social science, if you like, or a behavioral element to effectiveness that we need to consider. And that relates to matters such as the cultural sort of beliefs or cultural or political or social issues around mask wearing. There are issues around comfort, around whether people will actually wear them because of factors such as comfort and discomfort. And it may be that there is a difference between a finite air disaster event that might last for sort of 30 days vis-a-vis a general wearing of masks against a phenomenon that is always present. But this social silence element needs to be considered as well. Now, the contrast with the effectiveness principle is really what we call the precautionary principle, which is the idea that if there is a risk, even if there's not very much information, then action should be taken to protect human health. And this is kind of the idea that in this type of extreme hazard, then something is better than nothing. So it's better to recommend an intervention that offers at least partial protection than no protection at all. And if the evidence gaps exist, then that's not a reason not to recommend something, because if you do that, nothing will ever be recommended. And so it's thinking about how the precautionary principle plays against the effectiveness principle to determine what the comfort level is for recommendations and how those recommendations could be or should be framed. Autonomy. There are two facets to autonomy. One is the consideration as to whether to override individual autonomy to mandate mask wearing, which we saw occur in COVID. And the other is whether to not institute a mandate, but to encourage people to choose to wear masks. If the latter approach is taken, then to enable effective autonomy, we have to think very much about how do we enable that. And one of the ways in which we do that is clear public information. So we provide information not just about the nature of the risk, but also about the benefits and limitations of the actual intervention, how to fit masks so that people can maximize any protective effect, who can wear them, including suitability for children, what are the most effective kinds, for how long they can be worn and when, and so on. And it's about getting that information out to enable autonomous choice. And it's bearing in mind those social factors that Francesca has talked about in her presentation. Stewardship. It's really important to think about stewardship in the context of the financial resources that any sort of intervention might cost, whether that's a recommendation or whether that's an actual distribution of an intervention. There are significant costs associated with that, but that is always balanced against the consideration of the costs of not acting. So we know that there are often increased hospitalization, increased deaths, etc., associated with wildfire events, and whether the cost of making sure that there's clear communication with the public about the risks and benefits of the face masks is more or less better use of resources is really important. And so that could be through things like health impact assessments and so on to determine where the relative costs and benefits are. Equity, one of the significant issues that we grapple with when we work in this space is the question of equity. We know that there is unequal impact on particular individuals and population groups based on factors such as age, pregnancy, health status, socioeconomic conditions, and so on. And this is not just in terms of exposure, but also the ability to afford protective interventions. And these are really significant considerations that we need to think about. And we need to address those in the planning and in the messaging. Blake et al. Have written a marvelous paper which talks about the fact that preparation for disasters is something that is only for the privileged, because people can't necessarily afford to stockpile protective measures for things like earthquakes, and certainly may not be able to afford to wear good quality masks. And so how do we message around that? And how do we enable equity, if equity is something that's important to us? And given the unequal distribution of the risks, I would suggest that equity should be important. And then we come to trust. One of the things that we have seen in the context of the COVID-19 pandemic is really that trust in our institutions of government and our institutions more generally has been weakened. And that's been seen in globally, in some countries more than others. Certainly it's been noted in the research that compliance with government mandates, etc., was higher in countries like Australia and New Zealand, where there was significant trust in institutions, and less in other countries where there was less trust in institutions. Now, that is a massive issue and a massive problem. But one of the ways in which agencies need to think is what mechanisms and what measures can they put in place to increase trust in their recommendations. And so one of the sort of recommendations that we have, in which California is doing, is essentially working to transparently and with community input to work out where is the threshold at which a recommendation should be issued that masks are worn, and what is that threshold comprised of? Is it threshold values in terms of air quality? What should those be? Who should make that decision? When should that decision be made, etc.? And so we have this process flow diagram. And I would like to end by talking about current work. So this is the Face Up project that I'm a co-investigator on. We are funded by the UK Medical Research Council and the UKRI to conduct a research project in Indonesia and Nepal, in Kathmandu and Bandung, both cities with high, very high, extremely high air pollution caused by a number of factors. Within those two nations, we are doing a scientific arm of a study where we are examining whether face masks for children are effective, and the health impact, and undertaking a health impact assessment of that intervention. And in a social sciences study where we're working with children and families in those communities to work out what they would be willing to do, what they are able to do, etc., and what they know about the risks and the interventions that could offer some protective effect to their children. And part of that research is considering the ethics of this. And one of the things that we as a team are grappling with is that how do we message our findings? How do we translate our findings and work with communities to translate our findings in a way that doesn't create a moral burden for parents if we're saying you should be using an N95 when there, for a variety of reasons, such as logistics and cost, many will not be able to access that as a particular option. So how do we message that by making the evidence really clear, but taking away any moral stigma that they're feeling as a parent because they can't provide something that is optimal to enhance their children's health? And so these are really complex questions that we need to think about. And also we're working on the questions of resource allocation. And so how do resource allocation decisions get made in an environment of scarcity if you are thinking about distributing face masks for children? And I'll leave it there. And if anyone has any questions, I'm happy to answer them. Thank you.
Thank you so much, Fiona. That was very informative. I'm now going to pass it on to Leona and Priyanka, who are going to facilitate the next portion.
Thank you so much, and thank you to all of our wonderful speakers. You've definitely piqued my interest and curiosity here. Let's see, do we have any questions from the audience? Let's see. Mark has a comment, Mark Miller, that one vulnerable time period or population is pregnancy. And so can our speakers please comment on pregnancy in respect to the work that you presented?
Absolutely. And I actually meant to do that and forgot to, so apologies for that. Thanks for the question, Mark. So yeah, pregnant people are also uniquely vulnerable to inhalation exposures. You know, for one, there are just a lot of normal physiologic changes that happen during pregnancy that, you know, increase oxygen consumption and increase their minute ventilation and their cardiac output and all of that, right? So there's sort of all these rapid physiologic changes that happen during pregnancy. So they're also going to take in more air relative to non-pregnant adults. In terms of respiratory protection, you know, obviously, well, let me back up. Most people who are pregnant are going to fit adult-sized respirators. That's not true for everybody, unfortunately. But you know, those considerations in terms of the facial fit aren't too different. I think there are a lot of questions about safety in pregnant people, and it's again one of those areas that we don't have nearly enough data. The studies that exist have shown some differences between sort of different groups in various physiologic parameters when pregnant people are wearing respirators. And I'd sort of hand wavy say that because they're sort of hard to pick up a pattern at this point in those studies. It's just kind of wildly different. The one thing that does seem to be consistent is there's not an effect on fetal heart rate of wearing a respirator, at least for a short period of time. So I think, you know, to the extent that often pregnant people's concern is less for themselves and more for like, is this hurting my baby? I think we can be relatively confident that at least the limited evidence we have so far suggests that the fetus does okay. But yeah, lots of huge gaps there that are needed, you know, needed to be filled with some good research.
And I would add that for the purposes of the ethical decision-making framework, we would definitely consider pregnancy to be a group to which special consideration needs to be given. As Stephanie's just spoken about the issues around the wearing of the mask, but we know that without the wearing of the masks and with exposure, so not just masks, but wearing, but clean air in general, there is impacts on the gestation of the fetus, that there are issues with birth weight, for example, in relation to exposures and other developmental impacts on the fetus as on the fetus's growth and therefore on the child when it is born. So there's a very significant issue and a very significant population of people who need special consideration in that context.
And I can just comment briefly. Great point, Mark. Unfortunately, the work that I presented did not directly consider pregnant people. Part of that was in our interview sample, 45 people. We weren't able to recruit based on that characteristic. And we did interview a number of folks who had small children, though. And again, in our survey work, we actually did not collect that information. So as some of you may know, in social science, there are increased protections, the IRB protections for pregnant people. And based on the sort of broad questions we had, we decided to focus on people in some of the other vulnerable categories that were a little bit easier to access. So folks who are over 65, folks who reported existing chronic respiratory health issues, people who worked outdoors, and people who had small children in their household. So we did collect data on all of those, but unfortunately, not on pregnancy. So.
Great, thank you so much. Let's see. We have another comment. Available infographics on use of masks during wildfire events almost universally only recommend N95s and may actively discourage usage of any other options. Would each speaker care to comment on their opinion of this messaging? And yes, thank you so much. It's been wonderfully informative.
Perhaps I shall kick off on that one. In the previous project in which the ethical decision-making framework was developed, we were looking at the health impacts of volcanic ash-related air pollution events. We did some testing of various different types of interventions, from N95s to bandanas. We looked at bandanas that were looped around people's faces 3 times and dipped in water, and all those various permutations. And essentially, all of them offered some degree of protective effect. Obviously, the bandana type things and the wrapping around the face, whatever, etc., offered much less protective effect than a properly fitted N95 mask, but there was still a protective effect. And I think that we've got to think about the messaging of this from an equity perspective. If someone can't afford an N95 mask because they are a little bit cheaper than they were because of COVID, but if they can't afford it, or in the middle of a fire, it's not like you can nip down to the local hardware store and buy yourself, or a pharmacy or chemist or whatever it is you call it in the US, to buy N95 masks. And so you've got to use what you have on hand, and you shouldn't have to feel guilty about that, and you shouldn't have to feel burdened about that. You just need to know that there is something that you can do that will reduce, even if it's only slightly, the impact of inhalation in that moment in time. And so we've got to think about those equity questions around that messaging, and also what we do know about the protective effects that are offered by different forms of using the masks. And from a public health perspective, obviously, maximizing protection is best, but if we can't, some protection is better than nothing, in my opinion.
Great lead in, Fiona. Yeah, I mean, I think there, oh gosh, where to start? Maybe I'll start with one other equity issue that I'm sure you're aware of, but that you haven't mentioned. So I'll just say for our audience, and then talk a little bit about efficacy of different things. Which is that, I mentioned fit issues. One of these ways to be able to overcome that is to buy like a whole bunch of different kinds and have your kid try them on, right? Well, that also requires that you have lots of disposable income. And so, in addition to all of the other equity issues, right, you're then layering that on top that, my daughter both because I know a lot more than the average parent, but also, you know, I have the ability to buy 10 or 15 kinds of respirators for her to try. And, you know, if we don't end up using some of them, give them to somebody else. And, you know, I'm lucky to be in that position. So she has a much better fitting respirator than lots of kids. So just throw that one in there as well. I certainly agree, Fiona, the sort of, you know, we don't want to let the perfect be the enemy of the good, right? And it's so tempting to, you know, we need to wait till we have perfect evidence to make recommendations, right? That's not a great strategy. That leaves a whole bunch of people unprotected for a really long time. Or you know, we only want to recommend the thing that's perfectly best for people. That also leaves a whole bunch of folks, you know, without options and has all of the ethical implications, as Fiona was describing so nicely. I think the one thing that I'll add to what you mentioned is that I do know of some studies that have actually found some cloth masks to be not helpful, and examples of ones that actually have trapped particles closer to the face. So I am also a big proponent of recommending that people do other things if they can't, you know, if N95s aren't an option for a variety of different reasons. But I'm pretty cautious about recommending cloth, whether that's, you know, homemade. I like to joke that there's no, you know, N95 filtration aisle in Joann Fabrics, right? Like I can't go into the fabric store and go to the filtration of X% aisle to buy fabric. But also, you know, I'm a naturally suspicious person, and even, you know, people selling cloth masks that are, you know, official products, like until you can show me third-party testing, I don't believe you. So I am really cautious about those. But surgical or medical masks are actually often much cheaper and easier for folks to get. And whether that's, you know, a community distribution kind of program or individuals. The other thing that I often, sort of going back to the equity piece and tying that into the hierarchy of controls, is really trying to focus on what are other ways that people can protect themselves and their family that don't have a cost associated with them. So, you know, lots of communities have libraries or schools that have good HVAC systems. People might not know that, right? So like, what can we do in our individual community to figure out where those places are? You know, maybe it's the shopping mall that has like a public indoor space that like your kid can run back and forth for a little while if they need to get some energy off, and, you know, it's a place you can go. So I think there are those components too that are really key. Specific though, Elizabeth, to answer that, we actually, not to toot our own horn, but we do actually have an infographic at the PACU, and I'll drop the link in the chat to our Wildfire page. This is one that Mark and I worked on with some other folks. We've got sort of a whole poster as well as broken up into different components that does include some discussion of sort of what you could expect in terms of protection from a surgical mask as opposed to an N95. I will say, you know, that version of the infographic is aimed at the public, and, you know, there should be like massive error bars on there, right? Because it's just wildly different depending on how good the fit is. You know, there's some of that. Thanks, Elizabeth. There's some of that sort of got simplified out of there. But it at least, you know, gives the sense that you can get some protection. And I think that's the other key component, and maybe this is a good lead in for Francesca, which is that, you know, part of it is that we want people to understand at least somewhat what level of protection they're getting from something, right? That they have different behavioral choices that they can make, and that those, you know, they can all be beneficial in their own ways, but to not think that they are necessarily equal in terms of the health protection. And so how do we communicate all of that as well as possible?
Wonderful. You both covered so much, and I definitely agree. These are great infographics, Stephanie. So I was just browsing. And, you know, I think overall, I definitely agree that in terms of providing information about the types of masks, sort of showing people that there's sort of, you know, okay, better, best, that there's degrees of protection. You know, even if you go to, a doctor's office, and they'll sometimes have the surgical masks out for free. Those are more cost effective, and they're easier for people to keep on hand and give to one another. So I think especially in the case of wildfire smoke, surgical masks better than nothing. I know this workshop is about masking, but something that I feel like this whole conversation and doing this research on wildfire smoke has really helped me to understand is, again, all of these other ways that we can be taking action, and that people are aware of and they share with one another. So one of them is certainly closing up your doors and windows. Unfortunately, as we all know in the West, summers are really hot. And in some places, if people don't have air conditioning, or if they've been told by their utility to reduce their, draw on electricity, opening your door and window might be a way you cool your home at night in the summer. And so this is like kind of another behavior that I feel like it's really complicated for people, and people are making trade-offs. And so I think just to be aware that sometimes, we can provide this sort of best, most optimal action that people can take, but in the real world, they're going to be faced with these challenges, which is, okay, like I've had this N95 mask for a week. Should I keep wearing this old one, or should I wear this new surgical mask? Like, what's really better here? I mean, I think we don't want to discourage people from doing the best they can, but also kind of continue to try to fill in these gaps in these sort of odd situations where people may be faced with trade-offs. So, I definitely think things like even talking about air filtration, replacing your HVAC filters, replacing the filter in your car. I mean, Californians drive a lot, and the air filter in your car can get mucked up really fast during wildfire smoke events. And that's can be hours of time people are in their vehicle. So there are lots of other little things too that I think, we can keep pushing these types of communications and messaging to, again, try to fill those gaps and try to help people in situations where there may not be, they may not have the ability to take that absolute best action, but there may be some middling or assemblage of, middle actions that are helpful. So
we also have to think about people though who don't have any protection because they don't have housing. So I know that California, unfortunately, has a really significant homeless population, and they are incredibly vulnerable. It's not like they can shut their doors and windows because they don't have any, and their safety is dependent on their ability to access shelter, which may or may not be available.
I'll just say too, which is a slight tangent, but I think relevant to the discussion that we were just having, which is that, there have been some major efforts within the US to make improvements to the framework that exists for respiratory protection for the public, right? Because historically it's been all worker-based. There was a National Academies Consensus Committee that I sat on a couple of years ago that made some recommendations for what regulatory structures in the ideal fantasy magical unicorn world could look like. And one of the things that was centered in that was really the importance of coordinated communication, because I think one of the things that has been so problematic both before, during, after the COVID pandemic is that, when there is either an entire absence or really limited information, different folks sort of figure out how to fill that gap in knowledge in different ways. And I think that's some of how we've ended up with a situation where there's really conflicting messages going out to people, on top of which we as sort of a general public for a moment, don't really have a good understanding of where the expertise lies for respiratory protection. So I often, when I'm pulled into things, people are like, well, and then on this fact sheet we'll say you should wear a respirator, but if you have a concern, talk to your doctor. And I'm like, why? What does their doctor know that's going to be helpful? I can tell you it's nothing. Like we spoke about respiratory protection in med school for exactly 0 minutes. You know, and so I think there's a bunch of issues there too, in terms of like, where does the expertise lie, and how are we communicating to people what is known and what's not known, and you know, how best. It's a whole mess, as you all know. I'll stop.
Thank you so much. I wanted to just keep a mind on the time. We are at 4:30, and I wanted to thank our speakers again. We do have one more question in the chat if any of our speakers would like to answer that as we wrap up. But thank you so much for all of your expertise on very interesting information and topics that were presented. And I also want to thank all of our participants that were able to join and for a great discussion at the end. We will be planning to have one last workshop in our series focusing on the toxicology of wildfire smoke. So that will be coming up in the next month. So please be on the lookout for that. We will send out some information in a couple of weeks. But thank you again. It was great.
And I'm happy to hang on for a second and answer the final question that went into the chat, if that's helpful, Priyanka. But feel free to
sure.
go if you need to, guys. No,
Yes.
no offense.
Thank you.
Yeah, totally. So I don't know if you guys see, Alana asked whether there are effective reusable mask options. So it's tricky. Project N95 during the height of the COVID pandemic did a lot of sort of assessing various options that are out there, and you know, that's a good example of some third-party testing. There are a couple that they've found that seem to have some benefits. It's certainly not a widespread option at this point, though, which is really problematic. There's definitely discussion about that happening in sort of the respiratory protection community. The talk that I was part of this morning, there's a lot of discussion about that. You know, there's a variety of issues there, ranging all the way from capitalism getting in the way to, you know, how do you communicate to people? What's the difference between using it in a setting where you might be exposed to someone with TB and how often it's reusable versus wildfire smoke versus, you know, there's sort of all of these, a whole bunch of different layered things in there. Interestingly, the thing that tends to truly fail first if you're testing respirators is actually the head straps. The elastic tends to bust. And that's true also just for ones that are like in storage. There have been a fair number of studies looking at, like, you know, strategic national stockpile kinds of stuff. And that when things sit for a long, when respirators sit for a long time, what tends to fail first is the elastic on the straps, even if the filter media is still good, and sometimes nose pieces as well, right? Like the metal can get, the word I'm looking for, more brittle over time. And so those can also become problematic, whereas the filter media can last for actually quite a long time. Exactly how long gets really tricky. And, you know, there's definitely evidence that actually over time, filtration efficiency goes up as these things get loaded with particles, not down. Eventually you'll hit a breathing resistance where that's challenging. You know, exactly how many hours and at what level, and I don't think we've got really good answers to at this point. And so that's also part of the challenge. And again, I think we get conflicting messaging on it because there's all of those layers and complexities. But certainly, you know, if we're talking about something like wildfire smoke, where you're not worrying about a contagion issue, right? You can expect that you can wear them multiple times. If it's not soiled and it's still fitting your face, you're fine to continue re-wearing that. And, you know, I have an N95 in my glove box of my car for when the next time we have wildfire smoke. And I used it last summer, and I'll be honest, I expect that it'll work until the straps break, because it's been sitting in my car and the straps have got exposed to heat and they're probably going to snap at some point soon. But, you know, I rewear them. You know, I have, because I'm a klutz, spilled coffee on them. Probably not worth rewearing at that point, so I've thrown those out. But, you know, if it's not soiled and you're not having difficulty breathing through it, and you don't have a reason to think that it's contaminated from a sort of infectious standpoint, I think you can totally feel free to reuse them. The infection piece just gets more complicated. There was a lot of stuff during COVID about like, can you cycle them and how long do you need to leave them sitting for them to decontaminate? And if it's okay, I'm going to just sidestep that. But I'll say for wildfire smoke, yeah, I think you can certainly feel free to wear them repeatedly. And that's also a message that I don't think has gotten out to people as well as it should have.
Yeah, great. Thank you for that response. I think that's great points that you made there, Alana. Thank you for asking that question too. I don't think we have really heard as much about reusing masks for wildfire smoke. So I think that's another good point to think about. And then Leona, you put a question in the chat too. I don't know if you want to just ask directly.
I know we're over time. I just, Dr. Santana, I like the dad source. And it made me think about my dad. And so then I was wondering, like, did you get any sense of how, conspiracy theories and how that affects people using masks, for example, or adhering to having new actions, the protective actions?
Yeah, no, that's a great point. And I love this quote too, because right, everybody's dad source might be a little different. So yeah, so I think, when we did this research, it was pretty, I would say, early in people's experiences with these catastrophic smoke events. So the interviews were done 2018 to like the very beginning of 2020, right before the pandemic started. So, I would say the overall thing we were hearing from people related to information was just that they didn't have any, or that what they had was confusing, that they didn't have as much familiarity with the AQI. I think now, 5 years later, that is likely quite different. And I've done some follow-up research in California on compound wildfire hazards, so looking at smoke events and power shutoffs, and people have a real awareness of a lot of the types of information where they can find it now. So yeah, it's interesting. I haven't detected it, again, in this qualitative work, anything about misinformation or conspiracy theories related to masking and wildfire smoke. Although what I have detected, I would say, is a bit of a gendered component. So, and again, this is like all qualitative work, so I don't have any stats to provide, but anecdotally, especially in rural parts of Northern California, men who maybe work outdoors or have had like experiences with land management and forestry were more likely to downplay the risk of smoke on their health. And a lot of that was, they would say, oh, I have had all these experiences in the past being out there on a prescribed burn, or breathing in burns related to agriculture. And so there was this sense that they would talk about how they're not as susceptible as other people. It doesn't bother them as much as other people. Still a lot of concern and acknowledgement that smoke could be dangerous for children, older adults, et cetera, but a downplaying for them. So this is pretty complicated stuff, I think, like related to gender and occupation and masculinity and all of the cultural framing that kind of comes around that. But I do think that it's kind of an interesting component to mask wearing that I think, we did see maybe play out in a more obvious way during the pandemic, relate to masking and COVID. And yeah, the other thing I would say is in the survey work that we did look at political affiliation as well. And there was this a small but statistically significant difference between people who identified as Republican and people who identified as Democrats in terms of their intentions to wear masks for wildfire smoke. So again, it was small, and they were both pretty high, actually, intentions to wear masks for wildfire smoke across these two groups, but it was a significant difference. So I do think we could probably, I would assume that may have something to do with the political divide that has played out around masking and COVID has unfortunately perhaps kind of bled into the understanding and perceived effectiveness of masks for wildfire smoke.
Can I just chip in really quick? The National Academy's report that I mentioned earlier from 2022, that group of experts included some folks like Francisca that have a lot more expertise in behavioral stuff and communication than I do. But in, I think it's chapter 4 of that, which is talking about respiratory protection for the public, there's actually a fairly extensive discussion of communication and somewhat about how things have changed over the course of the COVID pandemic from battling lack of information to battling misinformation. So that might be, Leona, if you're interested, one spot to look at. Francisca, can I show you something that I discovered yesterday? Is it okay, Tessa or Amal, if I share my screen really quick? I was looking for masking pictures on Wikimedia Commons, which is a source of available. And I thought you might appreciate seeing this one, just your comment about sort of gendered perception about masks. I came across that one and I was like, oh man, that's quite the sentiment.
Oh my God.
And I just will chip in and say that I've read some more commentary than evidence than sort of science, if you like, recently, that the conspiracy attaches to the virus and or the government mandate as opposed to the actual mask, so that the context is going to be really important when it comes to those conspiracies around masking. That's
interesting. That hasn't been my experience when we get questions at the PACU, that like folks who are suspicious of masks, sometimes it comes from sort of the background related to COVID, even when they're asking wildfire questions. But
yeah, and that's why I wanted to temper it by saying it was someone's commentary rather than actually any empirical research on that. So it's an interesting speculation for someone to explore.
All right, well, thank you very much for taking the extra time to ask my kind of random question. And thank you everyone for attending. This has been a really great webinar. I appreciate all your time. And I look forward to the next one. It's really nice to meet you three. Thank you so much. Well, actually, I had met Stephanie before. But thank you so much for coming in and giving presentations.
Yeah, thank you so much. We really appreciate it. That was so great.
Thanks. This was great.
Thanks.
Yeah.
Pleasure. Thank you.
Bye.
Thanks all. Nice to see you all.
Bye-bye.
Bye, everyone.
Bye.
Bye.